Welcome to another lecture. This one is on the ankle and the foot joints. So what are some of the functions of the ankle? Well, this joint can support the body weight. It can control and stabilize the planted leg. It adjusts to irregular surfaces, assists with elevation, and some examples of this could be coming up on your toes, climbing, or jumping, and it helps with shock absorption of forces. The bones of the ankle joint are really just three main bones. The tibia, which is the medial bone, the fibula, the lateral bone, and the talus, which finishes off the articulation with the foot. On the tibia, the main landmark for our purposes is tibial tuberosity. We use that landmark when we start measuring ankle range of motion. The crest of the tibia is often referred to as the shin. And then we have the medial malleolus, which is the most distal prominent landmark on the tibia. The fibula is a thin, non-weight-bearing bone. Its primary purpose is to serve as a point of muscular and ligamentous attachment. The fibular head is the most proximal prominent landmark, and the lateral malleolus is the most distal prominent landmark, and both of these are used in goniometric measurements. The talus is one of the tarsal bones. It is the articulation of the foot with the lower leg. The anterior portion is the head, and the superior portion is referred to as the dome. This bone rather, is one of very few in the body that does not have any direct muscular attachments. The bones of the foot are comprised of three main groups: the tarsals, the metatarsals, and the phalanges. The tarsals include 7 bones: the talus, the calcaneus, the navicular, cuboid, and the 3 cuneiforms. Together we can group the talus and the calcaneus, and they form the rear foot, and the navicular bone, cuboid, and the 3 cuneiforms form the midfoot. The metatarsals are 5 bones that are numbered sequentially from medial to lateral, with the first metatarsal being the big toe. For all 5 of these bones, the base is the proximal part of the bone. It is a concave surface. The head is the most distal part of the bone, and it is a convex surface. And of course, the shaft is the portion that connects both. The phalanges are 14 bones that make up the toes, and they are also numbered sequentially from medial to lateral as the metatarsals are. The first toe has only 2 phalanges, and toes 2 through 5 each have 3 phalanges. The forefoot is made up of the metatarsals plus all 5 toes. The metatarsals and the phalanges together comprise the forefoot. The landmarks for the phalanges are the same as you find in the metatarsals. The base is the proximal portion of the bone, and it is a concave surface. And the head is on the distal part of the bone and is a convex surface. The tibiofibular joints, these are the joints made by the fibula on the tibia. So the articulations, there are 2. The proximal one is the fibular head and the proximal posterior lateral tibia. And the distal articulation is the lateral malleolus of the fibula with the distal portion of the tibia. The proximal joint has a joint capsule, ligaments, and other characteristics of a diarthrodial joint. So this is a plane or a gliding joint. It's a non-axial joint. Distally, it is held together by a very tough fibrous membrane. And so this is a syndesmosis joint. It has very minimal, if any, movement. The tibiofibular joint does allow some movements at the proximal joint since that is its only synovial joint. The gliding joint allows for very small movements but not in any one particular plane. Again, the distal joint is a syndesmosis, so the movement is minimal. The main role of this joint is to help stabilize the ankle joint. Again, the fibula is a non-weight-bearing bone. So if the distal tibiofibular joint does not move, this means that the majority of the movement is at the proximal joint. So since there is that gliding portion, there is going to be small movements, and this bone doesn't move very much either. Most movement occurs with dorsiflexion of the ankle. So if there is ever an instance with a patient that has limited dorsiflexion, this is one of the joints that should be checked to make sure that it is moving correctly, the proximal tibiofibular joint. As the ankle moves through dorsiflexion, the proximal joint allows a little gliding in a superior direction so that the ankle can move through full range of motion. The primary structure holding the tibiofibular joint together is the interosseous membrane. This is a dense sheet of connective tissue and it does not allow separation of the two bones. Which type of collagen fibers do you think comprise the interosseous membrane? The distal joint gets additional support from the interosseous ligament and the anterior and posterior tibiofibular ligaments. The talocrural joint is the ankle joint. The articulations are the doma of the talus with the distal tibia, and the lateral and medial surfaces of the talus with the lateral and medial malleoli. This joint is a synovial joint. It's a hinge joint and it allows 1 degree of freedom. So it's a uniaxial joint that allows sagittal plane movement in dorsiflexion and plantar flexion. The medial stability for this joint is due to the medial collateral ligament, or also referred to as the deltoid ligament. This is a large triangular shaped ligament that is composed of 3 primary segments. The 3 segments are actually several individual ligaments that are blended together. This is a very strong ligament, and fractures occur at the malleolus before a tear does of the deltoid ligament. So it's extremely tough and strong with firm connections. This ligament helps to limit end range eversion. So because it's so strong and because a fracture usually occurs before there's any actual tearing of the ligament, there's a term for this type of fracture, and it's an avulsion fracture. An avulsion fracture is when a part of a bone tears away from the main mass of the bone. Again, in this case, the ligament is so strongly attached that it pulls off the bone before it actually tears. And I'll show you an x-ray of what this would look like when it happens in reality. The lateral side of this talocrural joint is stabilized by the lateral collateral ligaments. And this is 3 individual ligaments. We have the anterior and posterior talofibular ligaments and the calcaneofibular ligament. These 3 together make up the lateral collateral ligaments. As a group, they are much weaker than the deltoid ligament. And its primary function is to help limit inversion and plantar flexion. As it turns out, the anterior talofibular ligament is the most frequently injured ankle ligament. So again, because this ligament's job is to limit end range inversion and plantar flexion, that means that when the ATFL ligament, the anterior talofibular ligament, is injured, it is because the joint has moved into an extreme range of motion in inversion and plantar flexion. When you hear the term an ankle sprain, this is the ligament that is involved. So as we move down the foot, we can start naming other joints that are also responsible for how the foot and the ankle function together for normal activities. The first one at the foot is the subtalar joint, also sometimes referred to as the talocalcaneal joint. but certainly subtalar is going to be the more common name you'll hear, the subtalar joint. The articulations for this joint are the inferior aspect of the talus and the superior aspect of the calcaneus. This is also a synovial joint with 1 degree of freedom. It allows some eversion and inversion to occur. These two motions are specifically foot motions and not ankle, so make sure you don't confuse the two. When we're talking about eversion and inversion, this occurs at the foot and not at the ankle. The subtalar joint is stabilized by all the ligaments of the ankle joint, so all the ligaments of the talocrural joint. But the most supportive ligaments for this joint are the talocalcaneal ligament, sometimes referred to as the interosseous ligament, and the cervical ligament. These two are the most responsible for holding the talus and the calcaneus together. This joint must allow flexibility for shock absorption during weight bearing and rigidity for propulsion. It rarely moves independently of the talocrural joint. The next joint distal to that is the transverse tarsal joint. Sometimes this is referred to as the mid-tarsal joint or Chopard's joint. This joint is actually made up of two different joints. The talonavicular joint, which is the anterior talus and the posterior navicular, and the calcaneo-cuboid joint. This is the anterior calcaneus with the posterior cuboid. Independent motion of these two joints does not normally occur, so they're often referred to as one joint. This is also a synovial non-axial joint. It's a plane joint. It does not allow any movement in any one plane. Its main function is to assist with eversion and inversion, and it mostly works with the subtalar joint in order to produce this movement. Additionally, it locks the foot to make it a rigid lever when we're ready to transfer forces across the foot, as with ambulation, or when you're propelling the body forward and upward. The transverse tarsal joint is supported by the plantar calcaneonavicular ligament. This ligament runs across the inferior part of the joint. It's also referred to as the spring ligament. It's a very thick, inelastic, triangular-shaped ligament, and it serves as support for the talus against weight bearing of the body in standing. The tarsometatarsal joints are the next distal joints. This is the link between the rear foot and the forefoot. Sometimes this section is also referred to as Lisfranc's joint. It is comprised of the 3 cuneiforms articulating with the base of the first 3 metatarsals and the cuboid with the base of the 4th and 5th metatarsals. This is also a synovial plane joint, so very little movement is going to occur, and it helps contribute to foot stability. The tarsometatarsal ligaments include the plantar ligament and the interosseous cuneometatarsal ligament. Both allow gliding between the tarsals and the metatarsals and support the joints. The MTP, or the metatarsal phalangeal joints, are the next distal joint. The articulations for these joints are the heads of the metatarsals with the bases of the proximal phalanges. This is a synovial condyloid joint which allows 2 degrees of freedom. It allows flexion and extension in a sagittal plane and abduction and adduction in a frontal plane. The interphalangeal joints are the most distal joints of the foot. These joints are the articulations of the heads of the proximal phalanges with the bases of the distal phalanges. So the first toe has 1 IP joint. and toes 2 through 5 have 2 IP joints. So that means that toe 1 only has 2 phalanges and toes 2 through 5 have 3 phalanges. In toes 2 through 5, the most proximal interphalangeal joint is often referred to as a pip and the distal one as a dip. All these joints are synovial hinge joints, so they allow 1 degree of freedom, and that is going to be flexion and extension in a sagittal plane. So all joints of the foot work together to stabilize or move the ankle and the foot. This contributes to propulsion of the body during gait and other functional tasks. So the rear foot again is the talus and the calcaneus together. These are the first point of contact with the ground during heel strike in a normal gait cycle. It is the initial weight-bearing part of the foot, and it influences the movement of the surrounding areas. The midfoot is again the navicular, the cuboid, and the 3 cuneiforms. With the help of the arches, this provides a blend of mobility and stability as we navigate uneven terrains and move through normal gait cycles. The forefoot is made up of the 5 metatarsals and all the phalanges. Each individual metatarsal and its corresponding phalange is referred to as a ray. So the forefoot is sometimes referred to as the rays. This part of the foot adapts to the level of the ground as well, and it is the last point of contact when we're trying to propel the body forward during gait. These are the muscles that dorsiflex and plantarflex the ankle, with the bold muscles being the prime mover. So for dorsiflexion, we have the tibialis anterior, the extensor hallucis longus, the extensor digitorum longus, and peroneus tertius. For plantar flexion, the gastrocnemius and the soleus are the prime movers. The synergistic muscles are the plantaris, tibialis posterior, flexor digitorum longus, and the flexor hallucis longus. In class, we will worry about organizing these by location and by innervation. These here are the muscles that act on the foot to evert, invert, and flex and extend the toes. For eversion, we have peroneus longus, peroneus brevis, and peroneus tertius. Sometimes these will be referred to as fibularis longus, fibularis brevis, and fibularis tertius. So you'll want to be able to distinguish and go between both names quickly, peroneus or fibularis. For inversion, the prime mover is tibialis posterior, and the synergistic muscles are the flexor digitorum longus and the tibialis anterior. The toe flexors are the flexor digitorum longus, which act on toes 2 through 5, and the flexor hallucis longus, which acts on the great toe. Toe extension, extensor digitorum longus, and extensor hallucis longus. And we will also do these muscles by location and innervation in class. So the muscles of the ankle and foot can be categorized into extrinsic and intrinsic muscles. Extrinsic muscles are those muscles that originate outside of the foot, so in other words, the lower part of the leg, but act on the joints of the foot. Whereas the intrinsic muscles, these have origins and insertions that are on the actual bones of the foot. The intrinsic muscles are used mostly for stability and balance or for assistance to the foot during activity. These intrinsic muscles work together as a group to support the arches as well. In the hand, we have intrinsic muscles, but the main difference between what you see in the foot and the hand is that in the foot, these intrinsic muscles work as a group. In the hand, they're able to work individually, which contributes to so much of the fine motor skills that we have available at the hand and how drastic it is between the hand and the foot. The foot intrinsics can be arranged in 4 layers. The first plantar layer is the most superficial, and then we move down to the second plantar layer, the third plantar layer, and finally the fourth plantar layer is the most deep. These are organized for you by by the layers in your muscle charts, so please refer to those to identify the specific muscles in each of the layers. As you might expect, there are also two joint muscles that cross the ankle and the foot. These muscles listed here are all the two joint muscles of the ankle and the foot. Additionally, the gastroc and the plantaris cross the knee joint. So the gastroc and the plantaris are plantar flexors of the ankle. If we wanted the gastroc to do the most work in plantar flexion, what position of the knee is necessary? So think about that and see if you can come up with an answer. Do the same for the soleus. If we wanted the soleus to do the majority of the work in plantar flexion, what position of the knee would be necessary? These other muscles, the flexor digitorum longus, hallucis longus, the extensor hallucis longus, and the digitorum longus, these muscles cross the ankle and the foot joints. Since these muscles act on the foot but cross the ankle also, what do you think this means in terms of ankle MMT? If we're testing the strength of the ankle plantar flexors and dorsiflexors, how do you think these other muscles can influence that movement or that strength grade? Can the knee and the foot positions influence range of motion at the ankle? So we talked about these influence in MMT, but think about this. Can the knee and foot positions influence range of motion of the ankle? So see if you can think of some of these answers, and hopefully we'll get a chance to discuss this in class. Of course, the muscles that cross the ankle and the foot can also work eccentrically and concentrically. As with the rest of the muscles of the lower extremity, these muscles also work mostly in a closed chain position. Can you think of how the ankle muscles work during walking? So think of a normal gait cycle. Which muscles that move the ankle work concentrically, and when? And how do the muscles that move the ankle work eccentrically, and when? So I'll give you a hint as you think about this one. We are talking primarily about the gastroc and its antagonist. The foot has three arches that we need to describe. These are the medial and the lateral longitudinal arches and the transverse arch. All of these arches are supported by the plantar aponeurosis, more commonly referred to as the plantar fascia, and the intrinsic muscles of the foot. These arches serve four main functions: to allow the foot to adapt to various surfaces, to absorb the forces during weight bearing, to provide a weight-bearing surface and a base of support for the body, and to make the foot a rigid lever for propulsion of the body. The medial longitudinal arch is the longest and the highest arch. When people refer to flat feet, this is the arch that gives that appearance. When describing an arch in architecture terms, the keystone is a wedge-shaped piece at the apex of the arch. This is the very last piece that is put in, and it locks all the other stones into position so that the arch can bear weight. So the arches of the feet also have keystones that help support it. For the medial longitudinal arch, the talus is the keystone. This arch lowers with initial contact of gait and raises with mid-stance during the gait cycle. The lateral longitudinal arch is lower than the medial longitudinal arch. The bones that are along this arch include the calcaneus, the cuboid, and the fifth metatarsal, with the keystone being the cuboid. During stance, this arch remains rigid or stationary. And finally, the last arch is the transverse arch. This is a concave, non-weight-bearing arch. It runs medial to lateral across the mid-tarsal and the tarsal-metatarsal joints, which basically are the cuboid and the three cuneiforms. This arch allows the foot to conform to the surfaces and to achieve loading response during gait. So that's the lecture for the ankle. We are now ready to move on to the lower extremity test. I'll see y'all in class.